Hi there and welcome to this video tutorial brought to you by Atoza. My name is Garth. In this video we will be discussing ventilation problems during anesthesia, including esophageal intubation, leak, autopeep or air trapping, high airway pressures, bronchospasm, and hypoxemia. We'll also be looking at abnormalities of carbon dioxide, including hypercapnia, and interpreting the capnograph. Let's get things started by looking at esophageal intubation. I'm not sure whether this should be part of the airway management talk or part of this ventilation talk, but it's such an important topic that we're going to cover it in both. The first ventilation step post-intubation is to assess the correct placement of the endotracheal tube. And waveform capnography is the gold standard for this. All clinical means of assessing correct placement of the endotracheal tube are inferior to capnography. This is a recent article published in the British Journal of Anesthesia on this topic by Baker, O'Sullivan, and Aziz. And in this article, the suggestions from the authors are that post-intubation, there should be a timeout with the sole focus on confirming the placement of the endotracheal tube. This should be done by a two-person review of the capnography waveform for confirmation of the tube placement. And during this period, one needs to observe a minimum of 7 breaths or 7 waveforms on the capnograph to be sure of our endotracheal tube placement. The authors suggest that if this method is applied, then there is 100% sensitivity and specificity for the test. This means that one will never miss an esophageal intubation with the endotracheal tube if we employ this method. So in summary, that's a timeout and a two-person assessment of the capnograph waveform, where one waits to see at least 7 breaths or 7 capnography waves on the trace. And this should take probably 30 seconds, which is not a long time. The authors do highlight that there may be times when this test is less reliable, and this may be in complex situations such as mediastinal tumors or low cardiac output states. And then they recommend the use of other aids at this point to confirm the correct placement of the endotracheal tube, such as repeat video laryngoscopy to confirm that the tube is actually going between the vocal cords, or fiber optic bronchoscopy to view the carina or the main bronchi, or transtracheal ultrasound to view the endotracheal tube within the trachea. The take-home message is that confirming endotracheal tube placement is vital to the safety of the patient, and one needs to watch at least 7 capnograph waveforms to be certain of placement. And as I said, this will take only about 30 seconds to do. Next, let's discuss the problem of an airway leak during anesthesia. Leaking of anesthetic gases is common during ventilation and anesthesia, and there are a number of causes of leak. This may include a misplaced airway device, circuit leaks, leak from the gas sampling line or the gas analysis. Certainly in older anesthetic workstations, they didn't return the gas from the sampling line to the circuits, and so there was always a minimum leak of around 150 to 200 mils per minute. Leak can also be due to high airway pressures that cause leak past the endotracheal cuff. Remember that we only inflate our endotracheal cuff to between 20 and 30 centimeters of water, so as to avoid damage to the trachea itself. And then if we have airway ventilatory pressures that are above this cuff pressure, then there will be leak past the endotracheal cuff. There can also be leak from the airways or the lungs themselves, such as in alveolar or bronchial fistulae. The features of a significant leak are a falling or collapsing bellows that fails to rise despite a fresh gas being added to the circuit. There can also be the audible sound of leak. There can be bubbling from the mouth or the nostrils. We can see low expired tidal volumes, which are lower than the inspiratory volumes. So a significant difference between the inspiratory and the expiratory tidal volumes. And one can also see a loss of the capnography trace. There are two immediate concerns with leak. The first is hypoventilation leading to hypoxemia and hypercapnia. And the second is inability to deliver anesthetic agents to the patient if one is performing a volatile-based anesthetic. And then, of course, there's the risk of accidental awareness under general anesthesia. If the airway is displaced and that's the cause of the leak, and the patient is at risk of reflux or vomiting and aspiration, then there's also the risk of aspiration in this form of airway leak. My management steps in the face of an airway leak are: firstly, I increase the fresh gas flow to at least 6 liters per minute or more if needed. I increase the inspired oxygen to 100%, and I adjust my vaporizer settings, and I set it at my desired Mach multiple level, which is usually 1 Mach. I have to make that change because now I've increased the fresh gas flow, and this changes how the vaporizer is calibrated. In some circumstances, I may also change to manual bag ventilation using the circuit bag as opposed to using the ventilator to get a feel for the ventilatory resistance, the lung compliance, and to try figure out from that where the leak is happening. So that's my initial management. I then move to examine the patient's airway. I look to see if the airway is still adequately secured and in the position in which I want it to be. This includes my strapping of the airway, the depth of the airway, and its general condition or position. I look for bubbles originating from the mouth or the nose, and I can also place my ear close to the airway and listen for leaks. If the leak appears to be coming from the airway, then there are a few options on how to manage this. If it's an endotracheal tube, I can check the cuff pressure. Maybe the cuff is underinflated, or maybe the cuff was torn during insertion of the endotracheal tube, and that's the cause of the leak. I can also re-perform laryngoscopy to confirm the endotracheal tube placement and its depth. If it's a supraglottic airway, I might want to resite the airway or adjust the airway position. I have a very low threshold for recommencing bag mask ventilation with a face mask if I am struggling to ventilate through a supraglottic airway with a leak and then proceeding to paralysis, intubation and ventilation and re-establishing control of the airway. That's specifically in the use of supraglottic airway devices. Then, if the leak doesn't appear to be originating from the airway or the airway device, I examine the breathing circuit for leaks. Common causes of leaks are disconnection of the gas sampling line, either at the Y connector or at the machine side, at the gas analysis side. Disconnection of the pressure sampling lines, if your breathing circuit has pressure sampling lines. It could be an open port on the heat-moisture exchange filter. It could be a tear in the reservoir bag, and this certainly has happened to me on quite a few occasions where between cases while I've been out of the theatre, someone has moved a piece of equipment over the breathing bag or rubbed up against the breathing bag and torn a hole in it, and then in the next case I suddenly realize that I can't ventilate and it's because the reservoir bag has got a hole in it. One can also have leaks from the soda lime if it's been recently changed between cases. And in my experience, one usually finds the cause of the leak fairly quickly and one can correct the issue quickly. But occasionally the cause of the leak evades one, and then I use the emergency ambibag, which must be present in every theatre for every anesthetic, to ventilate the patient and I connect it to the auxiliary oxygen ports of the anesthetic workstation. Using the AmbuBag like this rapidly gives me information on the airway resistance, compliance, chest rise. It also helps me to work out whether the leak is in fact coming from the airway or the patient end of the breathing system. One can still use the carbon dioxide gas sampling line in these conditions. One just has to connect it to the heat moisture exchange filter or the elbow piece on the breathing circuit, so that one still has the benefits of capnography while one is using the AmbuBag for ventilation. And then one has the benefits of this feedback and this information on that waveform. My focus has now shifted towards patient safety, while other members of the theatre team bring in a backup ventilator or try to correct the leak on the anesthetic workstation that we're working with. And it's important to remember in these situations that one will have to change to a TIVA anesthetic if one isn't already performing a TIVA, because we are no longer adding volatile to the system, and in fact with each breath using the AmbuBag we are blowing volatile out of the patient and out of the system. And so in my situation I would change to a propofol TIVA, as I can rapidly do this and I have the equipment to do it. But in other scenarios it may be more prudent to give a bolus of ketamine, 1 to 2 milligrams per kilogram, and this would afford you probably around 10 to 15 minutes of hypnosis or anesthesia while trying to work out a solution to your ventilator problem and your leak. If when you switch to the AmbuBag to ventilate, you are still unable to ventilate the patient, then the leak is happening at the patient end or at the airway device, not the breathing circuit or not the ventilator. And so you have to re-examine the patient or make a rapid adjustment to your airway device. So that was managing leak during anesthesia. Now let's discuss the phenomenon of auto-PEEP. Auto-PEEP occurs when expiration or exhalation is incomplete. Remember that exhalation is largely a passive process due to muscle and elastic recoil, and exhalation is also largely dependent on the small airway resistance, tone or patency. When exhalation is incomplete, the lung volumes don't return to baseline. So remember, in the first talk we spent quite a lot of time going through the fact that baseline is not zero. Our baseline at the end of exhalation is our functional residual capacity. And now what we're saying is that during incomplete exhalation, our functional residual capacity, or the volume that is in the lungs at the end of exhalation, is slowly increasing with each breath, because each breath fails to exhale the same amount of air that was breathed in during inhalation. And so this results in a progressive increase in this baseline lung volume, and as that occurs, the lungs increase in size, and so they increase in pressure, and we have a rising pressure within the lungs at exhalation. And this creates a vicious cycle where each further breath is worsened by the rising pressure within the intrathoracic cavity, which further limits the exhalation of gases during the passive exhalation phase. And so airway pressures continue to rise, and this can have significant effects on cardiopulmonary function. So relating to the heart, it can have negative consequences on venous return to the heart, and so it can reduce preload and it can significantly reduce cardiac output. It also significantly adds to right ventricular workload, and if there's any right ventricular disease or weakening of the right ventricular muscles, the right ventricle can fail. And then from a respiratory point of view, as the lung volumes increase and the intrathoracic pressure increases, so the compliance of our system worsens, our minute ventilation worsens, and we can enter a state of hypoxemia and hypercapnia. So that's a brief explanation of how auto-PEEP occurs. The causes of auto-PEEP are varied, It can be because of intrinsic airway issues. So those include asthma, where there is bronchospasm and increased tone of the smooth muscle lining the small airways, and so thereby limiting exhalation. Or it can be from chronic obstructive pulmonary disease, where the collagen and elasticity of the small airways are damaged, and so there is early collapse of those small airways during exhalation, and so we get air trapping in that form. There can also be other airway issues, such as secretions in the airways, or foreign bodies in the airways, or a kinked endotracheal tube that limit exhalation. Then other causes are ventilator issues. So this can be if our expiratory time is too short for the particular patient, and this may be because of an inappropriate IE ratio, but it also occurs when we dial in a respiratory rate that is too fast. And by having a fast respiratory rate, our inspiratory times and expiratory times proportionally decrease, and there might not be enough time for exhalation in this particular patient. So this picture here shows how auto-PEEP appears on our anesthetic workstation graphics. And what we can see is that the expiratory flow, which is underneath the horizontal line, doesn't return to baseline. It doesn't return to zero. And inspiration occurs while exhalation is incomplete. There may be other features of auto-PEEP on our ventilator graphics, and these can include an end expiratory pressure that is higher than the set PEEP. So at the end of exhalation, perhaps our airway pressure is 15 centimeters of water, and we've only dialed in a PEEP of 10 centimeters of water. That is a sign of air trapping. And this should actually trigger an alarm on the ventilator. I know it certainly does on the ventilators that I use in theatre. What we will also see is a progressively rising peak inspiratory pressure. And this is because as the lungs expand and have a higher resting volume and their resting pressure is increased, their compliance changes. And so our peak inspiratory pressure will be higher. Unfortunately, the alarms for this will only sound when the peak inspiratory pressure is higher than the set limit. And the limit normally defaults to 40 centimeters of water. So there has to be quite significant auto-PEEP before this alarm will trigger. And then what one will also see is progressive worsening compliance. So if one is on a volume controlled mode, we will see increasing airway pressures. And if we are on a pressure controlled mode, we will see decreasing tidal volumes for the pressure that we've dialed in. So one has to have quite a high index of suspicion for detecting auto-PEEP. And then looking at the flow time curve is certainly the best for seeing incomplete exhalation. We then move on to how we manage auto-PEEP. And this really depends on the cause. So if there is an intrinsic airway issue, my initial response is to increase my inspired oxygen concentration to 90%. I then disconnect my breathing circuit from the endotracheal tube and apply pressure on the chest with both my hands to manually decompress the chest and to facilitate a slow, prolonged exhalation over about 5 seconds. I then reconnect my breathing circuit to the endotracheal tube and I set the PEEP at 0 and continue to ventilate. If I'm using a volume control ventilatory mode, then I need to make sure that I remove the inspiratory pause if there is one. And like I said, I don't recommend setting an inspiratory pause if you're new to anesthesia, but sometimes certain ventilators default to having an inspiratory pause. And so you definitely need to remove this or set it at 0. I can then also increase the expiration time by making my IE ratio a ratio of 1:4. And then I slow the dialed in respiratory rate down to 8 breaths per minute. And these steps should allow a prolonged expiratory phase, and it should allow expiratory flow to return to baseline. So those are my initial steps. I'll go through the full bronchospasm management later in this talk. So that was if we suspect an intrinsic airway problem. If we suspect the problem is with our airway device, then we need to check the depth of our endotracheal tube to ensure that we don't have an endobronchial intubation. We can suction down the endotracheal tube with a soft, flexible suction catheter, which will confirm the patency of the tube and confirm that there are no kinks, but it will also suction out foreign bodies such as saliva, secretions, or blood. If we suspect the problem is with our ventilation mode or our ventilator settings, then we need to change the ventilator settings to increase our expiratory time. And I've gone through some of those already. That would involve slowing down the respiratory rate, increasing the IE ratio, and removing an inspiratory pause if we've dialed one in. So that's how I approach and manage auto-PEEP. So moving on now from auto-PEEP, let's look at our approach to high peak airway pressures. So to start with, one needs an idea of what constitutes a high airway pressure. And this can be relative or it can be absolute. So in terms of relative high airway pressures, any rising airway pressure relative to a previous value will make me suspicious. Also, any high airway pressure in a patient where I didn't suspect that I would be seeing high airway pressures will make me suspicious. But in terms of absolute numbers, any peak inspiratory pressure above 30 centimeters of water with an endotracheal tube carries the risk of damage to the lungs, and any peak inspiratory pressure of greater than 20 centimeters of water with a supraglottic airway is a problem because this may result in blowing air down the esophagus, gastric insufflation, splinting of the diaphragm, regurgitation of gastric contents, and other problems. So more than 30 centimeters of water with an endotracheal tube, or more than 20 centimeters of water with an LMA. Those are my numbers for when I start to worry. So just to recap, in terms of supraglottic airway devices, the ideal is to have a peak inspiratory pressure of less than 15 centimeters of water. And 15 to 20 centimeters of water is a bit of a gray zone, but certainly above 20 centimeters of water, we risk gastric insufflation. When I'm faced with airway pressures like this, if it's a very short case of 5 or 10 minutes, I may persist with the supraglottic airway, but in most cases, I paralyze the patient and I change to an endotracheal tube for this patient. And then I know that the airway is secured, that my risk of inflating the stomach is low, and I can relax and continue with the anesthetic and the surgery. In terms of endotracheal tubes, any peak inspiratory pressure of more than 30 centimeters of water is concerning and requires investigation for the cause and an attempt to optimize the ventilation to lower this peak inspiratory pressure. It's not always possible, but one should at least try. And then any peak inspiratory pressure of more than 35 centimeters of water is definitely a concern and is doing damage to the lungs. So my clinical management of high peak airway pressures is the following. Firstly, I employ safety steps to prevent further deterioration of the patient. I then try to diagnose the problem and I try to correct any problems or potential causes that I identify. So there's quite a lot going on at the same time, and this is a stressful situation when the airway pressures are high, especially if it's accompanied by hypoxemia or cardiovascular instability. So there's a lot going on and it's really important to have a well thought out approach to this problem. So my initial steps are to ventilate on 90% oxygen. I quickly then review the ventilator waveforms. I want to look for evidence of patient spontaneous breathing efforts because it might be ventilator dyssynchrony that's caused the high airway pressures. I want to look at the shape of the capnography waveform to see if there's evidence of bronchospasm. I can then also check for features of auto-PEEP, which is a expiratory flow that doesn't return to baseline before inspiration. I then also quickly review the ventilator settings. Are they appropriate? The respiratory rate, the tidal volume, the driving pressure, the PEEP that I've set in, the inspiratory-expiratory ratio. I usually at this point change to a manual ventilation mode because this gives me a feel for the airway pressure, and it also excludes a ventilator error or ventilator settings that are causing the high peak inspiratory pressure. And with experience manually ventilating enough patients, you'll get a feel for what normal compliance is, and you'll also get a feel for when the compliance or the pressure is really high and things are not right. While manually ventilating the patient, I auscultate the chest, and I do this with manual breath so that I can deliver large tidal volumes so that I've got the best chance of hearing the breath sounds while auscultating. What I'm listening for is the quality of the air entry. How loud is it, or is it reduced? Are there crackles? Are there wheezes? Is the air entry bilateral or is it unilateral? The next step, if one hasn't identified the cause, is to pass a soft suction catheter down the endotracheal tube and to suction in the endotracheal tube. By passing the soft suction catheter, we can confirm the patency of the endotracheal tube, that there's no foreign body blocking it, but also that it's not kinked in the back of the throat. And then we can suction down it to remove any blood or secretions or foreign material that may be blocking it. If the air entry into the chest with manual bag mask ventilation is equal and the breath sounds are clear and there's no wheeze and there's no crackles and the endotracheal tube is patent and it's at an appropriate depth, then it is likely that the problem is with the breathing circuit. And one can confirm this by taking an ambubag and ventilating the patient via the endotracheal tube with the ambubag connected to the auxiliary oxygen outflow. And what we'll find with the ambubag is that the pressures and the compliance are low and that it's easy to ventilate the patient with the ambubag. This is a quick way of reliably excluding the breathing device and the lung parenchyma or the patient as the cause of high airway pressures. And then that would point towards a problem with our circuit or our ventilator. If during auscultation we discover that there is bilateral poor air entry into the chest, or that there are crackles, or there are wheezes, or there's no air entry into one side of the chest, well then we've identified the cause of the high airway pressures is at the patient end. And these could be anything from a pneumothorax to an endobronchial intubation and unilateral lung ventilation to pulmonary edema to aspiration of gastric contents to bronchospasm or COPD or anaphylaxis. Another step that may be required during this process is to repeat video laryngoscopy to confirm the depth and placement of our endotracheal tube, and in certain circumstances, if you have it available to you, performing a fiber optic examination to confirm the position of the endotracheal tube relative to the carina, to look for foreign material in the airway and to suction that out, is also something that I do in certain circumstances. By far the commonest cause of high airway pressures at the patient end that I've identified are endobronchial intubations, a missed pneumothorax, especially in trauma patients, secretions in the airway, and bronchospasm. Just as an aside, while I think of it, it is important to also consider your heat-moisture exchange filter as a potential cause of high airway pressures. These devices can become blocked or clogged with foreign material. I've even heard of the plastic from the back of a ECG sticker being stuck in the filter and blocking the filter. And so I remove that filter when I'm faced with high airway pressures, and I see if it makes a difference to the airway pressure. It's not something that one's going to see as a cause often, but it is something that if you miss can result in severe harm to the patient. So don't forget that that filter can also be a cause of an obstructed airway. So in summary, when it comes to high peak inspiratory pressures, one wants to have a systematic way of assessing all possible causes of high airway pressure, starting normally at the patient end, which includes extrinsic factors that may be compressing the lungs, the lung parenchyma themselves, intrathoracic problems that may contribute to high airway pressures. Then looking at our airway, both the intrinsic airway of the patient, so secretions or foreign materials within the tracheobronchial tree, and then also looking at our endotracheal tube, whether it's blocked or kinked or malpositioned. And then if all of that is normal, moving on to the breathing circuit, which includes the heat-moisture exchange filter, the circle system, the unidirectional valves within the circle system, the ventilator, the APR valve, and other factors in the ventilator setup. And so by using an ambubag early on in the management of this situation, we can quite quickly separate out problems that are occurring distal to the endotracheal tube, so airway or patient problems, and we can separate those out from ventilator or circuit problems, and then have a systematic way of assessing for each of the common causes that may be going on, not forgetting to alert your team to the problem that you're facing and calling for help if help is available. All right, so we've discussed auto-PEEP and we've discussed high peak airway pressures. And so it's only fair now that we tackle the management of bronchospasm as an entity itself. So please note that although in this video series we haven't covered asthma as a separate topic or video lecture, we do hope that in further training modules we'll be able to cover the perioperative and intraoperative management of asthmatic patients. For now, we'll focus simply on the management of acute severe bronchospasm intraoperatively, which can occur in asthmatic patients and it can occur in non-asthmatic patients. So the first step in the management of intraoperative bronchospasm is its recognition. And we recognize it in a number of ways. First of all, there might be a high peak inspiratory pressure relative to the tidal volume that we are achieving. And this may result in the airway pressure alarm or a pressure limitation alarm sounding. We'll see upsloping of the Kapner-Graph waveform, which is very suggestive of bronchospasm. And we'll see auto-PEEP on the flow time curve. That means that there's air trapping and there's inadequate exhalation. If we listen to the chest, there will be wheezing on auscultation of the chest, or there may be very poor air entry bilaterally. Our initial management would be that we need to change our supraglottic airway to an endotracheal tube if we have a supraglottic airway in place. Then, as per our high airway pressure algorithm, we need to establish that bronchospasm is the cause of the high airway pressures. And this is done by ruling out other causes of high airway pressures, but also seeing the classic features of bronchospasm on our waveform on our monitors. We need to stop the surgical stimulus, as pain or surgical stimulus can contribute to bronchospasm. And we need to make sure that the endotracheal tube is not too deep and it's not touching the carina, because that can also trigger bronchospasm. Then we need to change our ventilation settings. First of all, we disconnect the endotracheal tube from the breathing circuit and we manually decompress the chest with our hands by putting pressure on the chest for 5 seconds and allowing hopefully complete exhalation. We increase the inspired oxygen concentration to 100% and we recommence ventilation with the PEEP set at 0 and our inspired expiratory ratio set at 1:4. We then also reduce our respiratory rate to 6 to 8 breaths per minute initially. And this is to try allow as long an expiratory phase as possible. This will result in hypoventilation and it will result in hypercapnia, but we can tolerate that initially. We must try to achieve a tidal volume of at least 200 mils, so at least some volatile and oxygen is reaching the distal airways. Also, if we are adding a beta-2 agonist such as salbutamol to our breathing circuit, then if our tidal volume is at least 200 mils, the salbutamol has a chance of reaching the smooth muscle of the distal airways. So that's our initial management and our initial ventilator settings. In terms of drugs, if we are doing a volatile maintained anesthetic with desflurane, we need to switch off the desflurane and change to isoflurane or sevoflurane and increase the fresh gas flow to a very high rate of 10 liters per minute so that we can wash out the desflurane as quickly as possible. One needs to increase the depth of anesthesia using our volatile anesthetic to a MAC multiple of 1 to 1.5. So we're aiming for a deep anesthetic level, and that is to afford as much bronchodilation from the volatile gases as possible and to ensure an adequate depth of anesthesia to reduce any surgical triggers of bronchospasm. We need to be prepared to administer vasopressors or inotropes in this scenario, firstly because of the bronchospasm, but then also because of our depth of anesthesia. And so we may need to administer ephedrine boluses or phenylephrine boluses. One should administer hydrocortisone 200 milligrams intravenously stat. One can administer magnesium sulfate boluses of 20 to 40 milligrams per kilogram. And then one wants to administer a short-acting beta agonist via the endotracheal tube as soon as possible. And ideally, one has a salbutamol metered dose inhaler present in theatre, and we can give 8 puffs down the endotracheal tube as needed. And it's likely that less than 10% of the salbutamol that we administer in this way will actually reach the alveoli. So we can be very liberal with our puffs down the endotracheal tube. There are a few ways to do this. One can place the canister of the salbutamol in a 50 ml syringe, and we can connect this to the angle piece of our breathing circuit and then squeeze on the syringe, and each squeeze will deliver 1 puff. Or one can connect some tubing to the 50 ml syringe and then pass that down the endotracheal tube deeper into the airway and administer the puffs via that tubing. We can repeat these salbutamol doses every 5 minutes, 8 puffs at a time. And just note that while you're doing this, the agent analyzer from your gas analysis module is going to start alarming, because it's going to pick up the salbutamol and it's going to be confused as to what you're giving in your anesthetic. And it will probably alarm that you're giving mixed agents or 2 agents, and you can just ignore that. If you have your fresh gas flow set at 6 liters a minute and you've dialed in your vaporizer to a MAC multiple of 1.5, then you can be certain that you're delivering a MAC multiple of 1.5 to this patient. So those are the initial drugs in the management of acute severe bronchospasm. Increased depth of anesthesia with the volatile, inhaled salbutamol, magnesium sulfate boluses, and hydrocortisone. Adrenaline is an excellent bronchodilator, and one may reach a situation where the hemodynamic effects of the bronchospasm or of the anesthetic that you're administering require an adrenaline infusion, in which case one can set up our standard adrenaline infusion and start it at 10 mils per minute. Or if you are suspecting anaphylaxis as the cause of bronchospasm, one should also administer a 0.5 milligram intramuscular bolus of adrenaline to treat the anaphylaxis. If you're unable to set up an adrenaline infusion, you can give 10 to 50 microgram boluses of adrenaline intravenously, and that will help for hypotension, and it will also help via systemic mechanisms to promote bronchodilation. Another systemic intravenous option is to administer intravenous salbutamol, and this we would only do if there is severe bronchospasm that is not responding to inhaled salbutamol. Administering intravenous salbutamol does carry risks, and there are some serious side effects or complications that can occur. One can develop severe tachycardia. One can also develop hyperglycemia. The beta-2 effect can result in significant peripheral vasodilatation and result in hypotension. And one can also develop hypokalemia. So intravenous salbutamol is not a first-line recommendation. We tend to reserve it for when there is severe acute bronchospasm not responding to the other treatment methods. We can give our intravenous salbutamol bolus of 250 micrograms over 10 minutes and then start an infusion of the remaining 250 micrograms over 60 minutes. In terms of aminophylline for acute bronchospasm, the use of aminophylline is very controversial because it has significant side effects too, and it is of limited benefit. And I would only use intravenous aminophylline when none of the above measures have been successful in managing severe bronchospasm. We administer it by giving a loading dose of 10 milligrams per kilogram aminophylline intravenously over 60 minutes. And it's important to stop the infusion if there is severe tachycardia or if arrhythmias develop. In terms of the further management of acute bronchospasm, if there is good response to treatment, then the surgery can proceed if it is time-sensitive surgery. One would want to avoid drugs that release histamine, such as morphine. One would want to avoid the non-steroidal anti-inflammatory drugs, as they can worsen bronchospasm. And we want to ensure adequate depth of anesthesia and analgesia during the surgery. When we reverse any muscle paralysis, we want to make sure that we give an adequate dose of glycopyrrolate with our neostigmine as part of the non-depolarizing muscle relaxant reversal. We then also need to plan for a high-risk extubation. And there are a few options here. We could extubate the patient deeply anesthetized and insert a laryngeal mask airway and then wake the patient up with the LMA in place. And hopefully this would cause less airway irritation during the wake-up phase. We could also get the patient breathing spontaneously and extubate them deep in a left lateral position and just hold a face mask lightly over the face until the patient wakes up. In either scenario, one should have a salbutamol 5 milligrams and ipratropium bromide nebulization available for the immediate post-extubation period. During the acute bronchospasm, we've said that we've given a stat dose of hydrocortisone, and we would want to continue prednisone 40 milligrams daily for 5 days post-operatively. We may also need to continue the salbutamol ipratropium bromide nebs as needed or 6-hourly post-op. And I would recommend involving a physician if one is available. So that's in a scenario where there is a good response to our treatment. If there is a poor response to our treatment, then we need to abandon the surgery if at all possible. So this is any situation where the surgery isn't immediately life-saving. Extubation in this situation will not be possible. One should not extubate patients that are having acute bronchospasm. And so we need to plan for ICU care or transfer of the patient to a facility that does have ICU monitoring. Just in case you're wondering what, in my situation, one can possibly do in acute severe bronchospasm that is totally refractory to medical management, well, we have access to ECMO, which is extracorporeal membrane oxygenation. And basically then we can place the patient on a heart-lung machine and then manage the patient in ICU until the bronchospasm is corrected medically. So that would be the end-stage management of acute severe bronchospasm in our setting, but that is beyond the scope of this talk, obviously. So just one of the key points that I need to highlight here is that I've managed acute severe bronchospasm on 2 occasions, and both of those occasions were probably actually my fault because I gave a poor anesthetic. The one case I remember quite clearly, we had an intravenous line that was not flowing properly. It was still intravenous, but it was not ideal for that situation, and we were doing a rapid sequence intubation in a patient for an emergency laparotomy. It was probably anesthetic underdosing in that because of our poorly working intravenous line, it took longer for the anesthetic drugs to reach the central compartment. And so when I intubated the patient, we precipitated acute severe bronchospasm. If we had just changed the intravenous line at the beginning, a free-flowing line and a rapid sequence intubation would have been better for that patient. And then the second scenario was in a patient with a ruptured ectopic and who was bleeding and who was mildly unstable, and we underdosed our propofol during our rapid sequence intubation. And I think that's what might have led to the acute severe bronchospasm that ensued. And it would have been much better for us to use ketamine in that intubation scenario, and because we were worried about the hemodynamics, at least give an adequate dose of ketamine and so protect the patient from the airway reflexes that weren't adequately blocked during our rapid sequence intubation. So there might have been other things that contributed to the bronchospasm, but those were certainly 2 things that I reflected on that I could have done better to try prevent bronchospasm in those scenarios. And luckily there were no negative outcomes for the patient, but it certainly was extremely stressful managing 2 relatively sick patients who now had added bronchospasm in the mix. So if we do the basics of anesthesia well, then we are less likely to get ourselves into these situations. So having a free-flowing IV line, giving an adequate dose of an appropriate induction agent, not advancing the endotracheal tube onto the carina during intubation, those are all things that can help to prevent acute severe bronchospasm. So then just quickly to touch on preoperative or postoperative acute bronchospasm. Well, here the focus is on confirming the diagnosis, assessing whether the bronchospasm is part of an anaphylactic reaction, initiating emergency management of the bronchospasm, and then in particular, which is what I want to focus on now, is monitoring for features that necessitate intubation and ventilation of the patient. And so this could be patients that we have been looking after as the anesthetist, or it could be patients that we're called to assist with in the hospital, patients that are having acute severe bronchospasm where intubation may be necessary. And part of our role in the team is to assess when we need to intubate the patient and commence invasive ventilation. So there's a list of features of severe acute bronchospasm that necessitates invasive ventilation, and these are if the SATs are less than 92% while receiving a nebulizer on 100% oxygen. That's a sign that this is severe bronchospasm that's likely to necessitate intubation. If our oxygen partial pressure on our blood gas is less than 8 kPa, again on a neb with 100% oxygen, that means that the bronchospasm is severe. If we see a rising carbon dioxide level or a carbon dioxide level that is above 4.5 kPa, this should point to the fact that the patient is fatiguing and that they are imminently going to have complete respiratory arrest. What we normally see in patients with respiratory distress or bronchospasm is low carbon dioxide levels because the patients are tachypnic, they're distressed, and in this process they blow off excessive amounts of carbon dioxide. So when the level is rising or it's normal, in other words above 4.5, then that is a sign that this patient is fatiguing and that they are close to respiratory arrest. If we auscultate the chest and we hear no breath sounds or no air entry at all, again, that's a sign of very severe bronchospasm. If, while receiving a neb, the patient has cyanosis of their lips or fingers or tongue, then that points to a partial pressure of oxygen of less than 8 kPa in the blood, and again necessitates intubation and ventilation. If we can see that the respiratory effort is febrile, or the patient is looking exhausted, or there is a reduced level of consciousness, or the patient is agitated, those patients require intubation and ventilation. If there is bradycardia or other dysrhythmias or hypotension in conjunction with acute severe bronchospasm, then again, those patients are most likely going to need intubation and ventilation. So when we pick up these patients with severe acute bronchospasm, we want to initiate the treatment for status asthmaticus at their current location, but then move them to a monitored resus-equipped venue as soon as possible. And this could be the theatre recovery room, it could be an operating theatre itself, or it could be a high care or ICU setting. We need to give salbutamol nebs continuously. One doesn't have to wait in between nebs. In acute severe asthma, we nebulize continuously. And we also want to give at least one ipratropium bromide 0.5 milligram neb. Again, we give our stat dose of hydrocortisone, 200 milligrams, and we can give magnesium sulfate 20 to 40 milligrams per kilogram intravenously over 10 minutes. If there is a poor response or pending intubation, we can give small adrenaline boluses of 10 micrograms at a time, or start a low-dose infusion, or we can give our intravenous salbutamol bolus of 250 micrograms over 10 minutes, and then start an infusion of the remaining 250 micrograms over 60 minutes. In these patients with acute severe status asthmaticus that are not responding to treatment, the use of aminophylline is probably acceptable, and so you can start an aminophylline infusion as well if you have it. It's unlikely to work in time, though, to prevent intubation if we're heading that way. In terms of intubating someone who's in acute severe bronchospasm, obviously all the preparation of our equipment and our drugs needs to be done as per standard intubating conditions. We want to set the ventilator before induction and intubation. And our ventilator settings are a PEEP of 0, a respiratory rate of 6 breaths per minute, an IE ratio of 1:4, and then a tidal volume starting at 200 mL with an inspired oxygen concentration of 100%. Those would be our preset ventilator settings. The team attending to the intubation and resuscitation of this patient need to be ready to immediately start CPR, because upon administering our sedatives and our muscle relaxants, there's a high probability that this patient is going to have a cardiac arrest at intubation. I would have an adrenaline infusion ready, and I would also have 1 amp of adrenaline mixed in a 20 ml syringe of saline ready for intravenous boluses of 50 to 100 micrograms at a time. We want to use an ambubag to pre-oxygenate the patient for as long as possible, ideally 5 minutes before induction and intubation, if this is possible. The drugs that I would use, if the patient is hypotensive, I would administer 20 milligrams of ketamine. If they are normotensive, I would administer 100 milligrams of ketamine to achieve hypnosis. I would then use succinylcholine as my muscle relaxant of choice because it has the fastest onset of action, and I want to recommence ventilation as soon as possible. After administering the ketamine and the succinylcholine, while waiting for the succinylcholine to take effect, I would manually decompress the chest slowly and gently by applying pressure with both my hands on the chest for 5 seconds. Once I see fasciculations, I will be ready to intubate the patient, ideally with a video laryngoscope and a bougie at hand, so that my first attempt is my best attempt. What I frequently do in these high-risk situations is, while I'm waiting for the drugs to take effect, I keep my finger on the patient's carotid pulse, so I can assess real-time their pulse volume and their heart rate, and I can detect changes in that may necessitate an adrenaline bolus or initiation of CPR. We then need to intubate the patient, And confirmation of the endotracheal tube position here is going to be extremely difficult because the air entry and chest rise is going to be very poor, and we may not have capnography monitoring at the venue we're in. So pay extra careful attention to your intubation and making sure that the endotracheal tube has gone through the vocal cords. We then connect our breathing circuit to the patient and we initiate ventilation if we are using a ventilator. If we don't have a ventilator and we're using an ambubag, we want to make sure that the PEEP valve on the ambubag is set at 0, and we want to do slow breaths at a rate of 8 breaths per minute, and initially just aiming for around 200 ml tidal volume at a time. The ambubags have a pressure release valve that releases pressure at 40 centimeters of water, and so it won't allow you to ventilate above that pressure. If you are unable to achieve any air entry without going above 40 centimeters of water, then you can hold in that pressure release valve with your finger while squeezing the ambubag, but then you need to pay extra careful attention to not delivering higher than needed tidal volumes. So just aim for 200 ml tidal volumes initially. Once the airway is secured and we are ventilating the patient, it's quite useful to get the patient onto an anesthetic ventilator as soon as possible because of the beneficial effects of volatile anesthesia on smooth muscle tone in the airways. And so if it's safe to do so, we can rapidly move the patient into the operating room, or if we're in an ICU environment, we can actually bring one of the anesthetic workstations into the ICU, connect it to the wall gases, and start ventilating the patient on the anesthetic workstation. And then our ongoing management will be as per what we've discussed for acute severe bronchospasm in theater. That includes salbutamol, metered dose inhalers via the endotracheal tube, a high-dose volatile anesthetic, the use of magnesium sulfate, the use of steroids, the use of salbutamol intravenously or adrenaline intravenously, and then possibly the use of aminophylline intravenously. So acute severe bronchospasm is a terrifying event, and no matter where we encounter it. And again, we need to have a well thought out systematic approach to this problem, including knowing all the drugs that we're going to use in the management, and then also being able to recognize when intubation and ventilation is necessary in patients that are not under anesthesia. Let's move on now to looking at abnormal carbon dioxide levels during anesthesia and then also capnography. So the normal capnograph waveform is a close to rectangular shape, and the waveform is consistent in shape between subsequent breaths, and the waveform returns to a baseline of 0. The peak range for carbon dioxide should be between 35 to 45 millimeters of mercury, and that correlates to 4.5 to 5.5 kPa. This is for routine anesthesia, and this doesn't apply in neurosurgical patients or in shocked or acidotic patients where we may specifically target lower carbon dioxide levels at times. So let's go through some of the abnormal patterns that we can see on the capnograph. So the first abnormal capnograph trace that we're going to look at is that of esophageal intubation. And what we see here is a progressive reduction in the height of the capnograph trace to a point where eventually the capnograph trace is flat. And this is why the guidelines that I've gone through earlier recommend that we watch for at least 7 capnograph waveforms to ensure that the endotracheal tube is in fact in the trachea, because esophageal intubation can still result in a few capnograph waveforms. The next pattern is that of a sudden large drop in end-tidal carbon dioxide level to 0, and this can be in a situation of cardiac arrest, in a situation of sudden apnea, from a dislodged airway, which can occur anytime if the airway is not properly secured, or from a disconnection of the breathing circuit from the airway. So that is a sudden drop in carbon dioxide level to 0. We can also have a sudden drop of carbon dioxide level to a low level, but not to 0. And we see this in situations where there is a sudden drop in cardiac output, which can be cardiogenic, for example, a myocardial infarction or cardiac arrhythmia. It can also be obstructive, such as in a pulmonary embolus. It can be distributive, for example, in sudden acute vasodilatation of anaphylaxis, and it can be due to hypovolemia, for example, in a sudden large hemorrhage, such as aortic injury during laparoscopic surgery. Then we would see a drop in carbon dioxide level, but not to 0. It can also occur in a partially dislodged airway, where only some of the expiratory gas is returning via the airway to the sampling line. The next pattern is that of a slow decrease in end-tidal carbon dioxide level. And we can see this in states of hyperventilation. And what we want to do here is check our ventilatory parameters, our respiratory rate, and our tidal volumes to make sure that we are not hyperventilating the patient. It can also represent a slow decrease in cardiac output. For example, slowly falling behind on our fluid resuscitation or our fluid replacement. The next pattern is that of a slow rise in the end-tidal carbon dioxide levels. And here, this can be caused by hypoventilation. And again, we need to check our ventilatory parameters, our respiratory rate, and our tidal volume. And it's important to remember that when we're ventilating any patient, there is increased dead space ventilation because of the endotracheal tube volume, the heat moisture exchange filter volume, and any extension up to the Y connector. And so it is normal to have slightly higher carbon dioxide levels during anesthesia because of this fact. Another cause of slowly rising carbon dioxide levels can be hypermetabolic states, such as sepsis, malignant hypothermia, thyrotoxicosis, and serotonin syndrome. And then also a depleted soda lime can result in a slowly rising end-tidal carbon dioxide level. And this is normally accompanied, though, by a baseline on the capnograph that is above the 0 level. So normally the capnograph returns to 0 during inspiration, and if there is depleted soda lime during inspiration, the level is not 0, it's 5 or 10, and that is diagnostic of depleted soda lime. And then the last abnormal capnograph waveform is the upsloping waveform of air trapping or a slow emptying of certain segments of the lung, and that is seen in asthmatic patients, in bronchospasm, and in patients with chronic obstructive pulmonary disease. So that is a brief summary of the various capnograph waveform traces that we can see during anesthesia. The last topic that we're going to cover in this video is our approach to hypoxemia or low saturations intraoperatively. Low saturations or hypoxemia can be a relative term, or it can be viewed in absolute numbers. For example, if our oxygen sats are 95% immediately post-intubation with an inspired oxygen level of 80%, I would at that point start to think that something might be wrong, because I would expect that with an inspired oxygen level of 80%, our oxygen saturations will be 98 or 100%. So why are they only 95%? The other thing that makes oxygen saturations or hypoxemia relative is it's relative to our starting baseline saturations. So in a patient who is known to have extensive lung disease, who's coming to theatre for anesthesia, and the baseline sats on this patient are 85% on room air, we're going to have different targets for our intraoperative sats and different understandings of what constitutes hypoxemia for this patient. And then thinking of it in terms of absolute terms, any saturations intraoperatively of less than 94% in a healthy individual, to me constitutes a danger sign, and I begin to investigate why the saturations are low. And it's important to remember that when our oxygen saturations are around 90%, then we are on the inflection point of our oxygen dissociation curve from hemoglobin, and any further reduction in oxygenation in the blood can result in a precipitous decrease in oxygen saturations. So one's on that steep point of that curve, and any further decrease and we slide down the curve and our oxygen saturations can drop to very low levels. And the other important thing to remember at this point is that it's the saturation of hemoglobin in the blood that is essential for the delivery of oxygen to the tissues, so that aerobic metabolism can take place and so that adequate energy generation can take place in the tissues. So we are very concerned about hemoglobin oxygen saturations. So there are a few causes of hypoxemia, and we can go through the theory of that now. Firstly, it can be an oxygen supply issue. So a low oxygen delivery or a low oxygen supply to the alveoli. And this may be because our inspired oxygen level is set too low. It could be from a pipeline oxygen issue where we are delivering a hypoxic mixture to the patient and we don't know that we're doing it. Or it could be because of hypoventilation. The minute ventilation of the patient is not adequate to maintain oxygen levels in the alveoli. And this could be because we've set a low minute ventilation, because there's a system leak, because there's high airway pressures, so our ventilation is hindered by those airway pressures. There are a number of causes of a low minute ventilation. The next cause could be a lung issue, and there are a number of problems that can happen at a lung level that can affect oxygenation. So there may be atelectasis causing shunt. There could be blockage of the alveoli by secretions or edema or infectious material or blood. Again, that will result in shunt. There could be a vascular issue such as a pulmonary embolus, which also results in shunt by increasing blood flow to other areas of the lungs, and that results in a perfusion ventilation mismatch and shunt. It could be from endobronchial intubation, which causes atelectasis and shunt. It could be from bronchospasm, which ultimately results in hypoventilation and hypoxemia. It could be from a pneumothorax, causing atelectasis and shunt. Then also at a lung level, it could be a diffusion problem across the alveolus into the circulation, and this could be anything that disrupts the thin alveolar capillary surface area, such as inflammation or secretions or edema that make it more difficult for oxygen to enter the circulation or to diffuse from the alveolus into the circulation, and that would then be a diffusion problem causing hypoxemia. And then it can also be a circulatory cause of hypoxemia. So in low perfusion states, one tends to get a worsened shunt within the lung because there is blood flow to the dependent areas of the lung, but blood flow to the mid zones and the upper zones of the lung is disproportionately reduced, and so there is ventilation perfusion mismatch in those areas and shunting. Then there can also be intracardiac causes of shunt, where we have right to left mixing of the blood within the heart, and so deoxygenated blood is mixed with oxygenated blood. And then lastly, there can be equipment issues. So there can be failure of the pulse oximeter or malpositioned pulse oximeter. Nail polish on the patient's fingers can affect the pulse oximeter reading. There could also be low cardiac output to the digit that the SATS probe is on, and so we could be picking up a low saturation because there is poor blood flow to the finger. This also occurs in patients that have got cold peripheries. Blood flow to the area is poor, and so there can be SATS probe error. There can be issues with the oxygen sensor calibration, And probably the most worrying one is if there's a piping or ventilator piping issue where we are delivering a hypoxic mixture to the patient and we don't realize it. So there are a number of causes of intraoperative hypoxemia. And just to summarize them again, we can have low oxygen levels reaching the alveolus. We can have diffusion problems at the level of the lung. We can have shunting within the lung. We can have shunting within the heart. And then we can have overall circulatory problems from the heart and then equipment malfunction. So our clinical management of hypoxemia is obviously very stressful because now the patient is deteriorating in front of our eyes. And so we need to employ safety steps to try to restore the situation while at the same time trying to diagnose the problem, prevent further deterioration, and manage the actual cause of the hypoxemia. So my initial steps in managing intraoperative hypoxemia are to ventilate with 100% oxygen initially, and then to check the waveforms on the ventilator, most specifically looking at the capnograph trace. And those are some of the traces that we've just gone through, because that will help me determine if there are problems such as a circuit disconnection, if there is hypoventilation, if there is a sudden reduction in end-tidal carbon dioxide, which might reflect a circulatory problem, if there's upsloping of the capnograph waveform, which might suggest bronchospasm. I then also want to check my overall ventilation parameters, including my respiratory rate, my tidal volumes, my PEEP, and my peak inspiratory pressure. I, at this point, will cycle the non-invasive blood pressure, and I will probably actually palpate one of the large arteries in the patient so I can get a sense of the cardiac output, the pulse volume, and the heart rate clinically myself. What I often do in these situations is I switch off the ventilator and I manually ventilate the patient using the reservoir bag so that I can get a feel for the compliance and the resistance of the breathing system. And at this point, I normally also auscultate the chest to listen for whether there's bilateral or unilateral air entry, the quality of the air entry, and whether there are any additional sounds such as crackles or wheezes. Based on these findings, I may want to check the of my airway. I may want to change my airway device from a laryngeal mask airway to an endotracheal tube. I may want to check the depth of my endotracheal tube, and I may also want to pass a suction catheter down the endotracheal tube to suction out any contents that may be present and to check the patency of the endotracheal tube. I usually then also look for features of central cyanosis such as a blue tinge to the tongue or the lips, which would confirm clinically that the patient is actually hypoxemic and that it's not an equipment malfunction problem. Similar to other situations of ventilatory problems in theatre, my go-to in these difficult situations is often the emergency ambubag, where I would then connect the ambubag to the auxiliary oxygen outlet on the anesthetic workstation, and then ventilate the patient using the ambubag, which gives me the most control over the ventilation and bypasses a number of the complexities of the anesthetic workstation and the circle system. I can take this even further and then open the oxygen cylinder at the back of the anesthetic machine and disconnect the anesthetic machine from the wall oxygen so that I know I am using oxygen from the oxygen cylinder via the ambubag and check whether that improves the situation. And this would be recommended when all other assessments of hypoxemia have failed to reveal the cause and one is now considering that there is a piping problem and an oxygen delivery problem to the patient. In my clinical practice, by far the most common cause of hypoxemia intraoperatively is because of atelectasis of the lungs and then shunting within the lungs. And as I went through in the first video talk on ventilation, There are a number of reasons why atelectasis can occur. It can occur during our airway management if there's a longer period of apnea. It can occur because of the way we've positioned the patient, for example, in a head down position. It can occur because of abdominal distension from large abdomens or from pregnancy or from laparoscopic surgery. It can occur just based on the patient's age and the fact that they're lying in a supine position. It can occur because our ventilation settings are not good. And so there are a number of causes of atelectasis, and often it is progressive during the surgery, and then the saturations start to drift downwards. And the correction of this is by performing a lung recruitment maneuver. And we also went through this in the first video on ventilation. The second most common cause of hypoxemia is probably secretions down the endotracheal tube or in the trachea. And then I find that when I suction these out with a soft suction catheter, the oxygenation improves and my ventilation actually improves significantly. So those are the two most common causes of hypoxemia in my practice, but we obviously need to have a systematic, thorough way of assessing all potential causes of hypoxemia so that we don't miss the rarer causes of hypoxemia, such as a pulmonary embolus or a pneumothorax. So that brings us to the end of this video lecture, looking at some of the complications we see during ventilation, aimed at the level of the learning or trainee anesthetist. No matter how experienced one is in anesthesia, it's always good to go through these essentials again, because these are things that we have to have an excellent framework of how to respond so that we don't miss the rarer causes of any one particular problem. So I found it extremely valuable going through this again. I hope you've enjoyed the tutorial too. And as always, please do stay in touch. Send us your feedbacks, your comments, and your questions. And take care and good luck out there.